Welcome to the first video in a series of videos that are about to come, presented by USMLE Forum of Pakistan. And what basically we do is we pick out questions inspired from famous QBanks. I'm not going to take their names, and we make our own questions and we provide you the explanations of those questions. The basic goal that I have kept for myself and for yourself is that by the end of this video, you should be able to identify certain patterns of problems that are presented in the question. Every question in the step one presents with a certain problem, and my purpose is for you to identify the patterns that will help you identify the problem. And once you identify the problem, what one thing that you can get out of that question, one high yield piece of information that is going to help you solve that question. That's it. We can discuss many tangents in every question presented in this presentation, but my goal would be here for you to get out that one basic high yield principle that is going to help you solve that question. All right, so let's begin. Now, this first question here represents, as I said, many important principles, but certain things that I want you to concentrate on. So let's just read the question together. Is that there is a 15-year-old male that develops cardiomyopathy secondary to Coxsackie virus induced myocarditis, and he's on the transplant waiting list. And after receiving a matched donor, which basically just means that he has undergone the transplant surgery successfully, he now presents with exertional dyspnea 2 weeks post transplant. Now, the workup is done, cardiac catheterization and biopsy is done, and they're saying that the problem must be acute rejection. Right, so they're giving you the problem. So I'm starting off with an easier question where you don't need to identify the problem, they're giving you the problem, and they just want you to give out the histological finding, right? So basically identifying the pattern of what the question is asking. The question is asking acute rejection, the histological finding of it, right? Of course, as I said, they have already given you the problem, but a few basic principles that I want to concentrate on is Coxsackie virus induced myocarditis. Now, Coxsackie virus has two variants, Coxsackie A and Coxsackie B. Coxsackie A causes hand, foot, mouth ulcers. And one high yield important thing that you must know is that Coxsackie A, along with two other infections, cause a rash that can involve the palms and the soles. And that mnemonic, which we use to remember those organisms, is CARS, C-A-R-S. C represents Coxsackie A, R is rickettsia, and S is syphilis. So these microbes cause a rash that involves the palms and the soles. So you have to remember that that is high yield on the NBME and in the USMLE. Coxsackie B, in my knowledge, causes myocarditis. Right? So Coxsackie B, you have to remember, causes myocarditis. And the definitive treatment is obviously transplant. That has been done. What you need to identify is basically what would be the histological finding. Now, this is important. You need to remember that. First of all, let's go through the options together. Let's start with the first one. Okay. Diffuse intimal hyperplasia in coronary arteries. Now, if you, this is just about knowing this factoid that this is the wrong answer because this is talking about chronic rejection. Okay, this is not an acute process. Hyperplasia is a chronic process. This does not happen acutely. Prominent lymphocytic infiltration between the cardiomyocytes. This is basically our correct answer. Why is it correct? We'll look at it in a bit. Focal myocyte necrosis granulation tissue formation. Now, this is the wrong answer because this is talking about, if you could remember, there were stages of myocardial infarction. which was basically what happens after 24 hours, what happens after 48 hours, what happens after a week. So granulation tissue formation in itself feels like an infection, a necrosis type of an option, right? So necrosis does not occur in granulation in rejection types. There are types of tissue rejection. There is hyperacute, there is acute, there is chronic, there is graft versus host disease. Now I should have explained that earlier, but point being that all of these stages are divided upon time. So as they've already given you 2 weeks, so they've told you acute rejection, but if they haven't, then acute rejection involves weeks, hyperacute involves minutes to hours, chronic involves years, and graft versus host disease is particularly around weeks to months. That happens when reticular endothelial organs are transplanted, like the liver, the spleen, the bone marrow. Spleen is never transplanted, but the bone marrow and the liver. So this is an necrosis or infection type of an answer, which will be wrong, obviously, because this is tissue rejection, not any infection. Now, eosinophils have no role in tissue rejection. They have no role, right? Well, this would obviously be the wrong answer. This is driven by lymphocytes primarily. Eosinophils have no role in that, in tissue rejection, any type of tissue rejection. And the last option is also wrong, which says minimal inflammation with the collagen deposition. This is basically scar formation, right? This is scar formation, right, guys? So scar formation is a process that is completely different than tissue rejection. So as I've already said before, my goal for this is for you to get out one high yield information, and your one piece of high yield information is that lymphocytes are involved in acute rejection, and acute rejection happens from weeks to months. That is it. All right, moving on. 54-year-old male with a history of coronary artery disease and has a bypass surgery, hospitalized for cough, dyspnea, and chest pain. And he is on his current drug regimen. Basically, they're asking you that that drug which he's on has shifted his ventricular pressure volume from the solid line, which is this line, to the dashed line, which is this line. And they're asking which parameter is most likely increased. Okay. So now you have to understand that the pressure volume loop has certain components to them. You have to learn this and you have to keep this in mind. These questions are not difficult. As I said, there is no problem presented to you. Everything is given. They just want to check how much you understand the graph in itself. Right? So basically just looking at it, we can understand that the graph goes like from here to here and from here to here. So it represents four phases of the cardiac cycle. Now, if you just look at this, the volume is increasing from point here to point this, right? From point A to point B, the volume is increasing. So obviously this is diastole or relaxation. And from this point to here, the volume is decreasing. So obviously this is systole. And what comes before diastole is isovolumetric, as you can see depicted by the same volume throughout the pressure change, isovolumetric relaxation, and then isovolumetric contraction. I have a picture that I want to show you guys. So basically what this is, filling and ejection, right? Now, the fact that we have to understand is that this area over here is the difference between the beginning volume and the ending volume, and this is known as the stroke volume. Okay, and this area over here is the preload. Why is this a preload? Because preload comes after the diastole phase. So this is the preload and this is the afterload. And why is this the afterload? Because the afterload comes after the systole phase, right? So you have to remember that. This is the preload, this is the afterload. So basically, if we just go back to our question, now let's look at the option. So we could already see that this area has increased, right? So the option would be C, correct option. But going through other options for completeness sake, let's look at ventricular preload. Right, the preload is the same because this point is the preload. So preload is the same. There's no change. Afterload has increased, but the preload is the same. This is the wrong answer. Ventricular compliance. Now compliance is basically this curve right here. This one. Right. Basically, this shows the change in the pressure with the change in the volume. So less volume and more pressure equals to less compliance. This is an example of decreased compliance which happens in restrictive cardiomyopathy where small amount of volume can give rise to big changes in pressure. So if this curve is steeper like this, which means it has increased, and if it's like this, which means it has decreased. But it's the same. So there's no change in that. So we'll cross it out. And systolic volume. Has the end systolic volume increased? This is very easy. This was the original volume. This is the new volume, right? This is the systole. So it's basically decreased, right? If you look at the graph, this is less volume, this is more. So this has decreased. So we're just gonna cross it out. And end diastolic pressure. This is the pressure, end diastolic pressure. If this would have decreased, then the dashed line would have been over here, right? This point, because this is where the diastole has ended, right? This is the where diastole is ended. So this point, this is the end diastolic pressure corresponding to this. So if this would have been over here, if the dash line would have been over here, then it would have decreased. Or if this would have been over here, then this would have increased. There is no change; it remains the same. That is the wrong answer as well. Okay. So increment is only in the stroke volume. Just pause the video and look at this picture and try to keep it in mind. It's quite simple. Okay, so looking at over here, there's a hypertensive patient and diabetic patient, 64 years old, that developed mild dyspnea following an emotional stressor, right? Hypertension and tachycardia, and ECG shows no acute ischemic changes. Okay, this is an important piece of information. A late diastolic sound is heard best in the left lateral decubitus position during end expiration. What is the etiology? They've again given you the problem in the question. There is no pattern to identify. They've told you everything. You just need the one high yield principle to look at it. Now, looking at the question, you can basically just cut off the extra answers. Papillary muscle ischemia happens in an MI, and there is no MI. So this is the wrong answer. There is no MI, and of course, this would result in a murmur, right? And we're not getting a murmur, right? Elevated ventricular filling pressures. Um, this would result in what you would say a different sound. This would result in a murmur. This would result in S3. This would result in a flow murmur, right? Not S3. Excuse me for that. Not S3. Okay. This would result in a flow murmur, right? So this is the wrong answer because if the ventricle is filling with more pressure, it cannot be a late diastolic sound. It has to be an early diastolic sound when the pressure, when the filling is actually started. When the filling is ending, it won't make any sound, right? Because the ventricle is already filled with it. So there's no point. When it starts filling, then that's the only point in which it can make a sound. So if you use some logic, you can get an answer right there. So this would be wrong anyways because it's a late diastolic sound. I cannot depict the filling pressure. Filling pressure is always depicted by the early sound when the flow is the maximum. Diastolic aortic backflow. This is the wrong answer because this is aortic regurg. This is aortic regurg, and this would again present with a murmur. right? And we have no murmur, so this is wrong. Mitral valve structural abnormalities. Again, valve abnormality. This would present with a murmur. No murmur in this question. They would have given you a murmur. They would have given you an audio file. Believe me. So the only option that we have is this one, and this is correct because concentric ventricular remodeling shows hypertrophy, right? We try to type it over here. Hypertrophy, and hypertrophy shows as 4. Now there are two sounds that we know: S1, which is an early systolic sound, and S2, which is a late systolic sound. And this shows the ending of systole. Then we have an S4, then we have an S3 in the middle of S1 and S2. So this is basic information. You have to know this. If we talk about S3, then S3 is is an early diastolic sound, and S4 is a late diastolic sound. So you have to remember that factoid. S3 shows, let me write over S3 shows um, dilated cardiomyopathy, dilated cardiomyopathy, and S4 shows hypertrophic cardiomyopathy. So you need to understand that. You have to remember that. You have to know that. That is very important. All right, you need to know that. Cool. Many high yield concepts discussed, but you need to know the sounds. All right. 33-year-old man presents to the emergency department with 1 week history, productive cough, worsening shortness of breath. He basically smokes 1 pack of cigarette, 2 to 3 alcoholic beverages every day, and intravenous heroin 2 to 3 times. This is a big red flag in the question, guys. You need to understand. You have to keep an eye out for that. He is febrile and he's tachycardic. And the blood cultures grow. Staph aureus and chest X-ray shows bilateral nodular infiltrates with cavitated lesions. Given this presentation, the most likely affected heart valve can be best evaluated by auscultation at which of the following anatomic locations? This is easy. Now, we have to identify the pattern. Intravenous drug user, blood culture that grows Staph aureus or Strep viridans or any other bacteria for that matter. Any heart problem, any murmur problem. Now, they've not given the murmur problem in this question, but they can in any other question. And any embolic phenomena, pain in the nails, pain in the chest, embolic phenomena stuck anywhere else. This gives rise to infective endocarditis. Drug use, blood cultures growing bacteria, and heart problem, most likely a valvular problem, a murmur given. This is infective endocarditis. You have to remember that pattern. And infective endocarditis by Staph aureus mostly affects the tricuspid valve, which would be in C. This would be the mitral valve. A would be the aortic, right? And B would be the pulmonic. So you have to first remember the points of auscultation. You have to remember that. Then you have to remember the pattern that I just gave you. And then you have to remember this factoid that infective endocarditis mostly affects tricuspid valve. That's that's it. All right. So female former competitive swimmer presents for a preconception consultation. She's in excellent health, regular menstrual cycles, maintain active swimming regimen since retiring from professional competition. Now she has no bad habit, no alcohol, substance abuse. Everything is normal except for the 60 BPM. This is bradycardic. This is not normal, right? And the physical exam is normal as well. Now, compared to a sedentary woman of similar age, which are the following adaptations, cardiovascular adaptations, would most likely be observed. So they're giving you another problem. They've given you the problem, the cardiovascular adaptation. So they're asking you any heart adaptation in an athlete with bradycardia. This is obviously pointing towards athlete's heart or the changes that the heart goes in athletes. So what happens is there is concentric hypertrophy, right? This is concentric hypertrophy, and this, this looks like more like eccentric, but you understand. And this is eccentric, right? This is dilated cardiomyopathy. So the athletes undergo concentric hypertrophy, which basically strengthens their heart. And what happens is because the heart is increased, so the left ventricle cavity size increased because the body needs more blood, right? The body needs a powerful pump. So because it's hypertrophy, the cavity size would increase. So we're just going to take out all the options that show decreased cavity size. Let's take out all the options. Half the options are eliminated. Now, the ejection fraction and the maximum cardiac output is a bit tricky. Ejection fraction always stays the same except for heart failure. All the pathologies in the cardiovascular system that I've come across till now pertaining to step 1, in heart failure the ejection fraction decreases, but in all of the other pathologies it remains the same. Pathologies and physiologies, it remains the same. So we are going to, because this is not a heart failure, so we are just going to um, cancel out the options that have a change in ejection fraction, because you see, if more blood is coming in, more blood is going out, so the fraction remains the same, right? And this is a physiological process, this is not a pathology, so you have to keep that in mind, that this is physiological. We left with two options, and the difference is we actually left with one option. We left with one option, sorry. So the correct answer is yeah, is this should be the correct answer, right in the end. This one, okay. Unfortunately, there has been some printing mistakes. Forgive us. So this should be the correct answer because the ejection fraction would remain the same, right? And the maximal cardiac output increases. This is correct. The function of the adaptation was to increase the output, and it has done so. Right? Even if you just pick out the two, you can actually pick out the third one in the exam. If you just figure out two arrows, you can figure out the third arrow as well. But as far as completeness sake, maximum cardiac output is increased because the left ventricle cavity is increased. So it is outputting more blood. The ejection fraction remains the same, but it is a fraction. The values in that fraction would increase, and when the time comes, the heart will get activated, and it's going to start pumping out more blood because the walls are now powerful. So you have to keep that in mind. That one uh, principle, you have to keep that in mind. So one thing that is important: athlete's heart is hypertensive cardiac adaptation, and it's normal. You have to remember it involves bradycardia in an athlete, and the cavity size would increase, ejection fraction will remain the same, and maximum cardiac output would increase. And that is it. As I said, I have tried to solve all of these questions as a student who does not have a lot of information, and we've used elimination method. The basic goal of this video is to equip you with exam solving skills, and we're going to try our best to do that. All right. So, USMLE Forum of Pakistan, please follow and comment. Thank you.